From Stockholm, Sweden, this is CardioSource video news coverage of ESC Congress 2010.
I'm here with Dr. Sanjit Jolly, and Dr. Jolly is an interventional cardiologist and assistant professor of medicine at McMaster University in Canada. And he just completed a study that addresses the question as to the optimal dose of heparin when used in conjunction with fondaparinux in patients with non-STE-ACS. So tell us a little bit about your study, Dr. Jolly.
Well, I think it bridges an important gap between the OASIS 5 trial and now this trial. We didn't know what the optimal dose of unfractionated heparin. We knew that you couldn't use fondaparinux alone during PCI, and now we have important guidance. We know that it's safe to perform PCI for acute coronary syndrome patients on fondaparinux, and we know that anticoagulation is important, that a standard dose regimen of ACT-guided heparin, as supported by the guidelines, is the approach that we would recommend.
So we knew from OASIS 5 that fondaparinux had some advantages over enoxaparin. However, it did cause thrombosis of a catheter, and so we know that heparin is recommended. You feel now that the optimal heparin therapy is the standard dosing.
That's correct. And I think the important issue is that fondaparinux uptake has been limited because of the concern of catheter thrombosis. And it was primarily the interventional cardiologist that had some anxiety and concern. And I think now we have randomized data in over 2,000 patients showing the safety of PCI in this population.
So now why would a lower dose of heparin not cause less bleeding than the standard higher dose?
I think there are some important issues. I think first, the trial has some limitations because of its size. But that being said, when you look at the historical trials, the primary differences in comparative head-to-head heparin trials in the angioplasty, balloon angioplasty era, the primary differences were hematoma and vascular access site bleeding rather than major bleeding. So I think historically, when you look back, these are consistent with those findings.
And do you think that the need to give heparin in conjunction with fondaparinux actually is preferable to just using enoxaparin alone?
I think the key issue, or one of the key findings from the trial, is that we did an analysis to specifically compare the major bleeding rates in FUTURA versus OASIS 5 PCI, and we adjusted for baseline characteristics. We wanted to know how the bleeding rates compare. And what we showed was when you add unfractionated heparin to fondaparinux, your bleeding rates were very low, very comparable to fondaparinux alone during PCI, and in fact significantly lower than enoxaparin. This suggests that this regimen of upfront fonda and then giving a dose of unfractionated heparin in the cath lab may actually be the safest in terms of bleeding for patients.
Well, that's important information for these patients with non-STE-ACS. For CardioSource Video News, I'm Tony DeMaria.